Hello friends, I am Professor Smita Jha from the Department of Humanities and Social Sciences, and as we are doing the course on health, humanity and disability, and under the caption today I am going to discuss feminist approach to medical humanities. The feminist approach to medical humanities exposes gender bias and power imbalances in healthcare, while the patriarchal approach relies on a traditional male-dominated hierarchy that treats the male body as the default medical standard. So, the core conceptual differences between the feminist and patriarchal approaches are: the first is the default body. Patriarchal medicine views the 70 kgs cisgender male as the universal human norm. Feminist humanities critique this, showing how it leads to misdiagnosed heart attacks and excluded clinical trial subject. Second is knowledge and power. So, patriarchal structure value objective, quantitative data controlled by a distant expert. Feminist approaches value situated knowledge, validating a patient's personal lived experience of illness. Third is medicalization. Patriarchal system tightly regulate and medicalize normal female life stages like menstruation, pregnancy, and menopause. So, feminist critique aims to reclaim bodily autonomy and view these stages without stigma. Fourth is language and history. So, patriarchal history celebrates a lineage of male founding fathers of medicine. Feminist humanities uncover marginalized voices like midwives and indigenous healers while analyzing how medical language pathologized women. So, key analytical frameworks used under this: the first is intersectionality, examining how gender bias multiplies when combined with race, class, disability, and sexuality. Second is biopolitics, which says that analyzing how institutional state power regulates and controls individual bodies, particularly reproductive choices. Third is epistemic injustice, studying how a patient's credibility is unfair discounted by medical professionals due to gender stereotypes. So, theoretical frameworks of feminist medical humanities speaks that the feminist approach to medical humanities relies on the rich framework of critical, philosophical, and sociological theories. These theories dismantle the patriarchal baseline of medicine by analyzing how knowledge is constructed, how power operates on the body, and how language shapes clinical care. So, the first is feminist epistemology and standpoint theory, and the core theorists are Donna Haraway, Sandra Harding, and the key concept is situated knowledges. An application is that this theory argues that all knowledge is produced from a specific social, historical, and physical standpoint. It critiques patriarchal medicine's claim to absolute, detached objectivity, what Haraway calls the God trick. In medical humanities, it asserts that a patient's subjective, lived experience of their own body is a valid, expert form of knowledge that must sit alongside laboratory data. Second is epistemic injustice and narrative theory, and the core theorists are Miranda Fricker, Rita Sharon, Arthur Frank, and the key concept are testimonial and hermeneutical injustice. Application is Fricker's theory explores how patriarchal structures systematically grant an unfair credibility deficit to women and marginalized patients, dismissing their symptoms as emotional or exaggerated. So, when combined with Sharon's narrative medicine, feminist scholars argue that treating the patient's story as a complex text to be interpreted rather than an unreliable complaint is an act of political and clinical justice. Third is feminist biopolitics and somatechnics. So the core theorists are Sylvia Frederici, Margareta Silderic, and Susan Bordeaux. And the key concept is the disciplined and the leaky body. Application is building on Michel Foucault's biopolitics. Feminist theorists analyze how the state and the medical establishment collaborate to control and regulate the reproductive working body. Bordeaux examines how medical culture enforces patriarchal beauty and weight standards, while Silric explores how the male body is historically theorized as contained and rational, while the female body is pathologized as leaky, unstable, and volatile. Fourth is intersectionality, and the core theorists are Kimberley Crenshaw, Patricia Hill Collins, and the key concept is compounding operations. Application is this framework insists that gender cannot be analyzed in isolation. It investigates how medical paternalism interacts with scientific racism, classism, and ableism. In the humanities, it explains why marginalized groups, that is, Black women, experience disproportionately worse medical outcomes, higher maternal mortality, and serve pain management biases due to overlapping systematic prejudices. Fifth is affect theory and disability studies, and the core theorists are Sarah Ahmed, Rosemary Garland Thompson, and the key concept is cultural politics of emotion and fit. Application is Ahmed explores how emotions like pain, fear, and fatigue are not just internal psychological states but are politically polished. Garland Thompson's concept of the misfit describes how a patriarchal, ableist world built around a standard male norm systematically fails to accommodate bodies that do not fit that baseline, leading to institutional neglect. So, intersectionality is the primary analytical lens used in feminist medical humanities to show how gender bias does not exist in a vacuum but multiplies when combined with race, class, ability, and geography. Coined by legal scholar Kimberley Crenshaw, this framework proves that a patient's medical experience cannot be understood by looking at gender alone. How intersectionality manifests in healthcare. So, maternal mortality rates, Black and Indigenous women experience significantly higher maternal mortality rates than white women. This disparity persists, controlling for income and education levels, proving that racism and sexism intersect to create deadly clinical outcomes. The strong Black woman stereotype, which is the second component of this category. So, medical providers often unconsciously rely on racialized gender tropes. This leads to the systematic undertreatment of pain for Black women as their symptoms are dismissed under the false assumption that they have a higher pain tolerance. Third is socioeconomic barriers, and a low income woman faces compounding barriers to care. She may navigate patriarchal gatekeeping regarding reproductive health combined with a lack of paid sick leave, lack of childcare, and poor transit access to clinics. Fourth is medical transphobia. Transgender women and non binary individuals face severe epistemic injustice. Their health needs are often pathologized or ignored by a rigid binary patriarchal system that links medical care strictly to cisgender anatomy. Fifth is colonial legacies. In the global south, patriarchal medical structures often intersect with Western colonial bias, and this leads to the devaluation of indigenous healing practices and the enforcement of foreign biomedical models that ignore local cultural realities. If we talk of biopolitics, it refers to the ways institutional state power, law, and medical authority intersect to regulate, manage, and control human bodies and populations. Coined by philosopher Michel Foucault, this concept is central to medical humanities. The centrality of this concept is due to the fact that it exposes how health, reproduction, and bodily functions are never purely biological, they are deeply political. The patriarchal and feminist approaches clash directly over how biopolitical power is used. When viewed through the lens of feminist medical humanities, biopolitics focuses heavily on how state power and medical authority collaborate to govern, discipline, and reproduce human bodies. While Michel Foucault laid the groundwork, feminist, queer, and post-colonial theorists revolutionized the concept. They proved that biopolitical control is deeply gendered, racialized, and unequal. So the patriarchal biopolitical framework, this patriarchal patriarchal systems use biopolitics to enforce social order, economic utility, and traditional gender roles by weaponizing medical authority. Key ways this weaponization happens are as follows. First is reproductive surveillance, regulating the fertile body through state laws and medical surveillance to maximize population growth or ensure economic stability. Second is pathologizing deviance. Well, historically using psychiatric and medical diagnosis to punish bodies that do not conform to patriarchal norms, that is, diagnosing independent women with hysteria or pathologizing LGBTQ plus identities. Third is the clinic as an agent of the state, positioning the physician as a state sanctioned gatekeeper who decides who qualifies for reproductive care, disability support, or gender affirmation treatment. Eugenics and population control, exercising state biopower to decide which populations are encouraged to reproduce and which are systematically restricted through forced sterilization or coercive family planning. Coming to the feminist biopolitical critic, so feminist medical humanities expose how biopower targets marginalized bodies and works to reclaim individual autonomy from state medical control. Significant ways through which this deconstruction is performed are reproductive justice, moving beyond simple choice to critique how systematic racism, poverty, and state surveillance strip women, particularly women of color, of their right to have children, not have children, and parent the children they have. Second is demedicalization or assistance, reclaiming natural biological processes like birth, menstruation, and menopause from rigid medical oversight and returning authority to the individual or community midwives. Contesting bodily surveillance, fighting back against corporate and state digital tracking of reproductive data, such as period tracking apps that can be weaponized in anti abortion legal climates. Transgender and queer liberation, challenging the biomedical state's authority to gatekeep gender affirming care and demanding that bodily modifications be treated as matters of personal autonomy rather than psychiatric pathology. Foundational theories connecting biopolitics to feminist medical humanities. The patriarchal accumulation of labor given by Sylvia Frederick, and the core text is Caliban and the Wedge, and the theory that is there, that is Frederici expand Foucault's biopolitics by arguing that capitalism required the state to subjugate the female body to produce the workforce. So medical humanities link, she traces how the historic persecution of witches was actually a biopolitical takeover. The state destroyed autonomous female midwives and indigenous healers, replacing them with a male dominated state sanctioned medical profession designed to control reproduction and domesticated women. Coming to the leaky and unstable body given by Margaret Sheldrake, core text is Leaky Bodies and Boundaries, Feminism, Postmodernism, and Bioethics. So the theory speaks that Sheldrake critiques the biopolitical standard of the normal body. Patriarchal medicine treats the male body as a self-contained rational machine. Conversely, it views the female body as fluid, leaky due to menstruation, lactation, and pregnancy, and inherently unstable. Medical humanities link, so this boundary breaking nature causes the biopolitical medical state to enforce heavy surveillance, regulation, and over medicalization on female and gender non conforming bodies to keep them contained and compliant. Coming to the necropolitics given by the Eshel Membe. Well, core text is necropolitics, and the theory is while biopolitics is the power to make life and let die, Membe introduces necropolitics, the sovereignty and power to dictate who matters and who is disposable. Medical humanities link is that feminist scholars combine this with intersectionality to study clinical neglect. It explains why Black, Indigenous, and trans bodies face higher mortality rates and medical abandonment. The state medical complex actively decides which population receive life-saving care and which are left to suffer systematic neglect. Fourth is genetic biopolitics and reproductive justice given by Dorothy Robert, Cortex Killing the Black Body. And the theory speaks that Robert exposes how biopolitical control targets women of color through stratified reproduction. While affluent white women are encouraged to use expensive reproductive technologies, marginalized women face coercive population control, forced sterilization, and criminalization during pregnancy. Medical humanity link is that this theory shift the medical conversation away from the liberal concept of individual choice toward a structural justice, analyzing how race, gender, and poverty dictate state medical interference in parenting. Coming to necropolitics versus neuropolitics. So, necropolitics and neuropolitics are two distinct theoretical lenses within the critical medical humanities. Both frameworks analyze how institutions use science and healthcare to control populations, govern identities, and determine whose lives are protected or allowed to fail. Well, necropolitics, coined by political theorist Achille Membe, is the sovereign power to dictate who matters and who is disposable, or who may live and who must die. While biopolitics focuses on regulating and optimizing life, necropolitics exposes the politics of death built into institutional system. In medical humanities, necropolitics critiques how healthcare systems actively produce death worlds through systemic neglect, resource allocation, and racial or social biases. It does this through the following ways. The first is medical abandonment. The state and the clinical institution use structural cuts and austerity measures to let vulnerable population die. An example analyzed in the humanities include the disproportionate mortality rates among elderly resident in underfunded long-term care homes. Second is clinical neglect and pain bias. Due to historical white supremacist and patriarchal medical framework, specific bodies are marked as less human. For example, the false belief that Black bodies feel less pain leads directly to clinical undertreatment and higher mortality rates, rendering these lives expandable within the medical machine. Third is sovereignty over the dead. Medical institutions have historically claimed the legal right to commodify, study, and exploit the bodies of marginalized or enslaved population without consent, treating them as mere biological tools rather than human beings. Neuropolitics and medical humanities. Neuropolitics investigates the complex interplay between the human brain, political behavior, and social power structures. In medical humanities, it intersects with critical neuroscience to examine how the modern medical establishment views human beings as purely cerebral subjects, reducing our identity, shuffling, and psychology down to brain scans and chemical balances. Neurofeminism versus biological determinism. Feminist neuropolitics critiques how brain imaging is frequently weaponized to reinforce gender binaries. Scholars expose how patriarchal science attempts to map male versus female brains to justify social inequities, fighting instead to show how the brain plasticity is shaped by cultural environment and systemic stress. Second is the neoliberal health consumer. Neopolitics critiques how mental health issues are framed strictly as individual brain disorders rather than systematic failure. By reducing depression or trauma to a chemical imbalance, the political state avoid fixing underlying social stressors like poverty or racism, pushing patients to become individual consumers of pharmaceuticals. Third is pathologizing neurodivergence. The medical model has historically classified brains that do not fit a productive capitalist standard as defective. Neuropolitics in disability studies works to reframe neurodivergence such as autism or ADHD not as a medical pathology to be eradicated but as a form of natural human variation being policed by an institutional state. Epistemic injustice. Epistemic injustice occurs when a patient's capacity as a knower is unfairly dismissed, ignored, or devalued by medical professionals due to a systemic gender, racial, or social stereotypes. Coined by philosopher Miranda Fricker, this concept explains why patriarchal medical structures systematically silence marginalized patient narratives, while feminist medical humanists actively fight to restore credibility to the patient's voice. The feminist approach to medical humanities addresses epistemic injustice by directly challenging the institutional power dynamics that cause epistemic injustice. It provides both a critique of patriarchal medicine and a framework for clinical reform. Coming to the feminist critique of medical knowledge, the first is deconstructing the objective gaze. Patriarchal medicine values a detached, purely quantitative perspective. Feminist scholars argue that this view from nowhere is actually a male view, which incorrectly labels subjective patient testimony as unreliable, emotional, or unscientific. Exposing language bias, the feminist lens shows how medical vocabulary has historically pathologized women's bodies. Terms like hysteria or somatization are exposed as rhetorical tools used to explain away physical symptoms when medical science fails to find an immediate answer. Third is uncovering systematic gaslighting. This approach demonstrates that medical gaslighting is not just a collection of isolated incidents involving bad doctors. Instead, it is a structural features of a patriarchal system that trains clinicians to trust diagnostic machines over human narratives. Coming to the next aspect, that is the two core forms of epistemic injustice. Testimonial injustice. A doctor gives an unfair deficit of credibility to a patient word due to prejudice. In healthcare, this looks like a clinician dismissing a woman's severe physical pain as mere anxiety, stress, or exaggeration. Second is hermeneutical injustice. A patient lacks the collective social language or medical vocabulary to understand and communicate their own structural mistreatment. For example, before the feminist movement conceptualized postpartum depression, sexual harassment, or chronic fatigue syndrome, individuals suffered in isolation without the words to make their doctors understand. So, the feminist solution, restoring epistemic justice, validating situated knowledge, coined by theorist Donna Haraway, this concept asserts that all knowledge is embedded in a specific context. In medicine, a patient has a unique, expert understanding of their own lived body. Feminist humanities argue this subjective data is just as vital as a blood test. Coming to the next aspect, advocating for narrative medicine. Pioneered by Rita Sharon, narrative medicine trains doctors to listen to the patient story like a complex text. It teaches clinicians to honor the patient's voice, look for metaphors of pain, and respect the patient as a co author of their own care plan. Third, creating new categories of illness. Feminist medical humanities provide the academic and social space to name unrecognized condition. By listening to marginalized patient, scholars and activists have successfully pushed conditions like fibromyalgia, chronic fatigue syndrome, and long COVID out of realm of psychosomatic and into legitimate medical research. Patriarchal norms versus feminist intervention. So, patriarchal monopolization, patriarchal medicine values only objective, quantitative data like blood test or a scan controlled entirely by the professional expert. So if the test come back normal, the patient's subjective qualitative testimony of suffering is often treated as invalid or psychosomatic. Feminist narrative medicine. Feminist medical humanities treat the patient narrative as vital clinical data. By validating situated knowledge, this approach argues that a patient holds expert knowledge about their own unique lived body that a diagnostic machine cannot capture. Coming to the real world manifestation in healthcare, so the Yantel syndrome. Women presenting this archetypal cardiac symptoms are routinely underdiagnosed or misdiagnosed because their heart attacks are historically conceptualized based on male physiology. Their testimonies of discomfort are systematically misread. Psychologizing physical disease, autoimmune condition, endometriosis, and fibromyalgia, which predominantly affect women, take an average of 4 to 10 years to properly diagnose. Patients are routinely sent to psychiatrists or told their chronic pain is all in their head. Medical gaslighting, this I have already discussed earlier also, which is the intersection of racial and gender bias compound epistemic injustice. With this, I just wrap up the entire discussion. Let us meet in the next lecture. Till then, thank you.